Hi, good morning. I'm Nitin, spine fellow from Leeds. The topic of my presentation is use of drain in spine surgery. So the use of the drain started by Hippocrates mainly for the abdominal and the chest surgeries. He used to use a lot of holes in the drain tube made up of gold, silver, and lead. And then Ambrose Pare modified it with the use of less number of holes. So I searched the number of articles with post-operative drain in spine surgery, and at present there are around 8,500 articles. This is one of the video by B. Shivshankar, one of the orthopedic surgeon from India. He's showing how to remove the drain which is stuck because of the suturing. So what he is showing is uses a long K wire to be inserted through the drain, and that long K wire cuts the micro stitch into the drain and helps in removal of the drain fragment without the exposure of the wound. This is one of the papers showing asymptomatic patients with retained soft tissue drain fragment. Leaving the fragment in situ is a treatment option that deserves consideration, and they have not removed this drain fragment, and they have almost like 15 months follow-up. So this is the first study in 2017 showing the drain do not reduce the incidence of complication in the anterior cervical discectomy or fusion, one or two level posterior cervical fusions, lumbar laminectomies, lumbar decompressions or discectomies, and posterior spinal fusion for adolescent scoliosis. So this was the study showing the overall infection rate in the spine surgery was 5.7%, which is quite high, with 6.2% among the patients with the drain compared to the 4.9% in patients without drain. So definitely patients without drain, the infection rate is less. Now the fixation technique. So in most of the centers, they use a fixation technique called figure of eight, but I was searching the literature and there is nothing about the literature in it, about even in the Royal College literature, and I found the one paper with the fixation method, which is a foolproof. So you just have to make a vest along the drain with few knots. There is no need basically to put multiple simple knots around the drain. So people put around 9, 10 knots so that the drain doesn't come out, but that is not required as per this technique. And this is the paper from the Germany showing in terms of indication, duration, and the safety measure use of drain in spine surgery is heterogeneous. The majority of the surgeons in Germany prefer drain. Even in microdiscectomy, 31% of the surgeons they put drain. So this is the paper showing the risk-benefit analysis of wound drain uses in spine surgery. It is a systemic review and the meta-analysis with evidence summary. The paper has been published in 2020 July in the European Spine Journal. So the drain in spine surgery was a practice made out of the habit rather than guided by the evidence, since there is no evidence. And to prevent the formation of the epidural haematoma, which could cause the neurological deficit by its mass effect on the dural sac and increasing the tension on the incisions, resulting in wound-related complications. So basically, the use of the drain is the double-edged sword. If we use it, few people think it prevents the infection, but it potentially causes the retrograde infection, increases the postoperative blood loss, which increases the need for blood transfusion. So in this systemic review and the meta-analysis with evidence summary, we compare the various potential outcomes with and without the use of drain spine surgery. So they have divided the different spine surgeries into the different aspects, except for they have not included the spine infection and the bony tumors of the spine. They included the patients undergoing spine surgery. Intervention was a wound drain. Comparator was no drain, and the outcomes like surgical site infection, hematoma formation, total blood loss, total transfusions, wound soakage, seroma formation, wound dehiscence, reoperation rate, length of hospital stay, neurological injury, study design, both prospective and the retrospective studies. And they excluded the patients studies with like case series and studies without comparator group. Spine surgery is performed in infected spine conditions, no subgroup analysis if the main intervention in the study is not the usage of wound drain, and no defined patient characteristics, including the pathology addressed and the surgery performed. So they searched around 2,574 articles. Out of that, they have included only 23 articles. So basically, I'll just uh, come to the results. So anterior cervical spine surgery, there is no benefit of the drain. Spinal cord tumor excision surgery, there is no benefit of the drain. It does not reduce the CSF collection. Drain probably does not reduce the reoperation rate as well. The drain probably does not reduce the length of the hospital stay. Spine trauma surgery, there is no use of drain. Thoracic lumbar degenerative spine surgery, there is no use of drain. So we'll come to the discussion of this paper. The lumbar spine surgeries for single level degenerative did not find any superiority from the use of wound drains, either in preventing the surgical site infection, reducing the hematoma formation or reoperation rate. Moreover, significant increase in the length of the hospital stay, which could further contribute to increasing the risk of surgical site infection. It reduces the epidural fibrosis and reduced size of the epidural hematoma, but this is mainly in the radiological studies. Now, the prophylaxis of surgical site infection in adult spine surgery, and this is the systemic review in this article. The multiple level posterior spine surgeries, they are more in favor of putting the drains if the surgery is multiple to prevent the reoperation or hematoma formation as recommended by this study. But this was the only study. Now, the meta-analysis by Lewittel noted significant reduction in the saturated wound sockage by involving two underpowered studies with 113 subjects in total. The study utilization of the drain did not confer any additional benefit, but only increased total blood loss. Anterior cervical spine surgery in this study did not uh, so the drains not only failed to reduce the risk of the hematoma formation or the surgical site infection, but caused increased total blood loss and length of the hospital stay. Intradural spine surgery, the use of drain did not alter amount of CSF collection, but it resulted in increased reoperation rate and length of the hospital stay. Cost benefit analysis considering around 88,000 lumbar decompression surgeries, only decompression surgery performed in the United States in 2010, amounts to over $2.6 million would be spent for use of drains alone without any additional benefit to the patient. So there is a lot of money is also involved. Then strength of the study, the domain-specific assessment of role of drains in various surgical scenarios. Inclusion of the studies where the patient with and without drain could be clearly identified and compared. Inclusion of the several retrospective cohort studies in this review, which had sample size of greater magnitude to demonstrate statistically significant effect on the outcome. Limitation of the study, it was a heterogeneous study design, lack of universal drain fixation and the removal protocol. Data on exclusion of the patients with coagulopathy was not available in all the included studies. The study is limited by small number of the studies in specific domain with inherent methodological flaws. So to conclude, the routine use of the drain in various domains of the spine surgery does not reduce the risk of surgical site infection, and their absence did not increase the risk of the hematoma formation. High quality studies to address their use in the spine surgeries in the cervical trauma and the tumor domains are required to further strengthen the evidence synthesis from the available literature. So take home messages: hematoma, seroma, and the wound dehiscence. There's no difference whether you use drain on not. Blood transfusion, it increases the chances of blood transfusion. Secondary surgery, there is no difference. Wound infection, no difference. Wound dressing, it increases the number of dressing. Basically, it increases your the dressing on the day, second or third day whenever you are planning to remove the drain, and definitely increases the length of the hospital stay. Thank you.